Louise. Thanks, everyone. Thank you, everyone. And merci bien encore, Louise, pour l'invitation d'être ici. Merci à vous. I know you're very busy, but it's just a delight to see so many and such diverse faces represented here in this room today. It's a great pleasure to be here. I want to begin by acknowledging the territory on which we stand today. Thank you. And this is my conflict of interest disclosure slide. And for those of you who are here for continuing medical education credits, I believe that you received the learning objectives. So let's get started. I hope today in the next 35 minutes or so that I'll be able to share with you and create an impression with regards to the importance of addressing social health inequalities amongst young people, which I hope you will agree is important for young people themselves, but I hope what you also will come to understand is how important the health of young people, and in particular young adults, is for everyone in society as a whole, especially going forward into the future. I will also share with you examples from my own program of interdisciplinary research and extremely intersectoral research. And in doing that, link that up with a number of interventions that I hope and believe and remain very engaged in attempts to address social health inequalities and the health risks experienced particularly by marginalized young people. So many of you are very familiar with the life course literature, which to a large extent has focused on the very important period of early childhood, before age 3, before age 5. But I think it's safe to say that there is an emerging consensus within the literature that other periods of life and the life course are critical points of development. And we know that capabilities and capacities acquired between the ages of 12 and 30, for example, adolescence and early adulthood, underpin health and well-being throughout the life course and also affect people's capacity to engage in work, family life, and communities. We also know that the period of being young, adolescence and early adulthood is elongating. It's growing as societal trends and indeed biological trends occur. And here we think of how in almost every nutrient-rich context we see earlier onset of puberty, and we also see the influence of changing economic patterns and social patterns and norms associated with various phenomena like globalization and migration, and how those influence delayed adoption of so-called adult roles such as marriage, entry into the full-time workforce, leaving home. All these things tend to be occurring later in life. Most of my research for the past 25 years or so has focused on young people's health, and in particular their sexual health and social inequalities in sexual health, addictions, and gender-based violence. So 3 broad groupings. And my work has informed a wide range of interventions both inside the healthcare system as well as interventions in other sectors, and in particular, as I mentioned this morning to the group of students, within the legal sector. But I do just want to recognize that the examples that I'll talk about today are from my work, but I really want to recognize and acknowledge the great work that's happening here in Quebec and elsewhere. And in this piece, recognize a collaboration between a Quebec-based researcher, Thierry Gagné, and a UBC-based researcher, my colleague Jerry Veenstra, that I think is a great example of empiricizing and showing us the importance of developing policy, programs, and other interventions that address this important and yet often neglected period of development, early adulthood. And I commend Terry for taking on this analysis. And of course, the editor of the Canadian Journal of Public Health is also here. So I'm grateful to Madam Editor for ensuring that this piece reached our eyes. I've had the opportunity to spend a long time working on health inequalities with respect to young people's health. I've worked in Vancouver, which you see here. I've worked in other parts of British Columbia, other parts of Canada, and various places throughout Brazil, the UK, and France. And of course, Vancouver looks absolutely lovely here, doesn't it? But I want to be clear that this is actually the Vancouver where I've spent most of my career and most of my time, working in Vancouver's downtown east side neighborhood, the downtown south neighborhood, and primarily working with young people who use illicit drugs. Also working with young adults and primarily young women working as sex workers, and with young gay and bisexual men living in Vancouver. My work, as I mentioned, has been highly intersectoral, and it has informed 2 cases heard by the Supreme Court of Canada, including this case with my colleagues, Dr. Kate Shannon and colleagues at the Gender, Sex and Health Initiative, that informed a Supreme Court ruling regarding sex workers' rights to safety and security as guaranteed under the Canadian Charter of Rights and Freedoms. And I've also worked for many, many years with my colleagues, Dr. Evan Wood and Dr. Thomas Kerr, formerly at the BC Centre for Excellence in HIV, now co-leading the BC Centre on Substance Use, including our work together around the Supreme Court case pertaining to Insight, North America's first supervised injection facility. Those are pretty high-profile examples of some of our work, but what you may not be as familiar with is some work that we've been engaged in since 2005. It's a cohort study funded by the US NIH and by CIHR, a cohort established by my colleague Thomas Kerr, and myself, Thomas, and others have been very much engaged in this thing called the At-Risk Youth Study, which documents social, economic, and environmental factors that influence the health and well-being of street-involved young people in Vancouver. We use interviewer-administered interviews and surveys, clinic visits, and a program of longitudinal, deep ethnographic work to follow and document the health inequalities experienced by over 900 young people living in Vancouver. And this work has informed harm reduction interventions such as syringe distribution, housing initiatives in Vancouver specially designed for young people, and stigma reduction efforts, including those that were designed to build new relationships between street-engaged young people and the police, as well as new relationships with city planners and City Hall and other city officials. But despite this massive amount of work that we've done around issues facing young people who use drugs in the past couple of decades, I have to say that all this experience has done, you cannot imagine what it's like to be at the epicenter of the current opioid overdose crisis. It is surreal. And I'm sure you're very familiar with the announcement made in April 2016 by the Chief Public Health Officer at the time, Dr. Perry Kendall, who declared a public health emergency in response to the escalating overdoses and deaths. Since the emergency was declared, over 1,400 families have lost a loved one due to overdose. This slide shows the age-specific illicit drug overdose death rates for the past 10 years. And as you can see, overdose deaths really began to escalate in 2015. I'm not sure how to do that, but you see 2015. That was when the illicit drug supply in Vancouver began to be contaminated by fentanyl and fentanyl derivatives. And you'll also note that where the red arrow is, the age-specific overdose death rates for young people has doubled in the past 2 years. And this is something that you don't hear a lot about in the media, but it is deeply concerning to those of us who work every day with young people and lose young people to overdose every day. And as a matter of fact, since the emergency was declared, 541 young people have died due to illicit drug overdose in British Columbia. So as governments, ministries, and community civil society organizations urgently seek to invent, adapt, scale up innovative addiction treatment services alongside primary prevention, my colleague, Dr. Danya Fast, and I are engaged in a program of research to provide evidence to inform next steps in this unprecedented context. And despite not really knowing exactly what to do or precisely how to do it beyond our emergency response, Vancouver has rapidly expanded addiction treatment options for young people. And this is a major intervention because prior to the opioid crisis, addiction treatment services in Vancouver for young people were virtually non-existent. In 2015, Vancouver Coastal Health Authority issued a new set of guidelines to make Suboxone a first-line treatment for use in overdose in young people. It had never been done before. They also opened 17 new residential treatment beds specifically for young people, and are attempting to enhance continuity of care. And Danya and I are working closely with partners throughout the community and with the support of a new 5-year CIHR grant to provide real-time information and data to directly inform ongoing efforts to deliver and scale up these and other innovative responses to the youth overdose crisis. And of course, partnerships are crucial to any of this kind of work. And through the At-Risk Youth Study since 2005, we have extensive, long-standing partnerships with young people who use drugs, and with the civil society organizations that they have formed, including with Indigenous young people. We've also developed partnerships with clinicians and healthcare decision makers who are really trying to provide the very best possible interventions to young people. And these partners include people like the new Chief Public Health Officer for British Columbia, Dr. Bonnie Henry, through to emergency room clinicians at St. Paul's Hospital, the downtown hospital where many overdose patients are received, to workers at youth shelters, outreach workers, clinicians at detox centers, and even parole officers. So this is the situation for street entrenched young people. But in addition to young people who are deeply involved and deeply street involved, there's a risk increasingly for the effects of a contaminated illicit drug supply to affect other people who use substances for recreational purposes, including fentanyl-contaminated crystal meth and fentanyl-contaminated cocaine. And one group that is very important and at-risk group, if you will, for overdose and various other outcomes are young, gay, and bisexual men. In fact, in British Columbia, the combination of substance use and sexual risk are really creating grave concerns with respect to young, gay, and bisexual men's health. The sexualized use of substances appears to be on the rise in this population, and this is a risk that is further compounded by overdose risk stemming from the contaminated drug supply, recreational drug supply. And epidemiological evidence also links high-risk sexual behavior with drugs like meth, drugs like cocaine, and depressants like alcohol. And all of this is occurring in a context in British Columbia where we see escalating sexually transmitted infection, including HIV rates, as this graph, oh dear, I haven't clicked, there we are, as this graph indicates. So we're seeing a potential reemergence of the HIV epidemic amongst young gay and bisexual men. So if you look at the green line, this is reflective of incidence rates of HIV amongst young gay and bisexual men born between 1980 and 1999. And look at the trajectory of that green line and realize that as compared to the decreasing rates we see in the older cohort, the yellow line, those gay and bisexual men born between 1980, unless that green trajectory changes direction in a significant and rapid way, we estimate that the current generation of gay and bisexual men will soon have similar HIV prevalence to earlier birth cohorts. And this is very, very concerning. Sort of like a perfect syndemic, if you will. So we know that sexualized use of substances, including alcohol, provide important opportunities for intervention. These are things we can actually do something about. And there's lots of evidence from cross-sectional work to show that drinking, for example, and in particular, heavy episodic drinking is associated with sexual risk behavior, HIV seroconversion, low adherence to HIV medication. But most previous research has ignored the potential impacts of understanding the impacts of heavy episodic drinking exposures during critical periods of the life course. So heavy episodic drinking during young adulthood, for example. And very few studies have examined questions related to these kinds of exposures over time and the potential accumulated effects of these exposures over time. So fortunately, my colleague, Dr. Brandon Marshall at Brown University and some other colleagues as well had an opportunity to begin to unpack some of these questions using a large longitudinal data set from a sample of gay and bisexual men living in 6 cities in the US. And this study is originally known as the EXPLORE study. And Ken Mayer, when he designed this study, he designed it originally as an HIV study, and almost all the HIV outcomes have indeed been published. But we wanted to use this powerful longitudinal data set to examine patterns of heavy drinking over time in order to better understand how the timing of heavy episodic drinking exposures during certain periods of the life course, young adulthood, might be linked with concomitant and accumulating risks. So what we did was this. Oh, before I get into the trajectories, I want to show you this. So just to be clear, you can see from this mountain plot that the vast majority, this light color, if you will, of gay and bisexual men in this study are not heavy drinkers. They're not classified as heavy drinkers, but 14% of the study, these 3 bottom colors, darker colors, do fall into what we derived as a definition for heavy drinking, which we defined as the number of days in which 5 or more alcoholic drinks were consumed in the past 6 months. So we use longitudinal group-based mixture models to identify 5 heavy episodic drinking trajectories and to determine correlates of membership in each of those trajectories. So the blue line at the bottom here are people who never drink. They're teetotalers. They do not drink. The black line way at the top would be reflective of a pattern of drinking heavily every single day during the previous 6 months. And membership in the 3 heaviest drinking trajectories, the red, the yellow, and the purple trajectory, equate with red, drinking heavily for more than 100 days in the past 6 months, yellow between 40 and 80, and purple between 20 and 40 days. We know that in these trajectories, these patterns were associated with both current alcohol-related problems and with a greatly increased risk of excessive alcohol use prior to or during sex. We also showed and found that participants with increased heavy episodic drinking were more likely than their non-heavy drinking counterparts to report commencing drinking at a younger age, having experienced childhood sexual abuse, and self-identifying as white. But interestingly, and I want to spend a little bit of time on this throughout the rest of my presentation, also reporting low levels of educational attainment, more likely to have not graduated from high school. And we also thought it was important to understand whether membership in specific heavy drinking trajectories would be correlated with changes in depressive symptoms and substance use over time. And as this figure shows, depressive symptoms as captured by the CESD scores on the y-axis, that increased very frequent heavy drinking, the red and the yellow line, is associated with escalating depression symptoms over time. We also undertook a subsequent analysis. We just couldn't get enough of this data set. A subsequent analysis to examine socioeconomic gradients in depressive symptoms, again, these CESD scores, amongst this sample of gay and bisexual men who have sex with men. And in brief, this work was undertaken in part by a wonderful former PhD student of mine, Dr. Basha Pakula, and my colleague Brandon Marshall, and many others as well as myself. This analysis showed that amongst this sample of gay and bisexual men, those who earned lower incomes, those who could not hold or even obtain full-time employment, and those who had less than a high school education reported more depression, and that higher depression scores were concentrated in lower levels of the social gradient. Now, none of you will be surprised by any of this, but let me tell you what I do find amazing. I find it absolutely astounding that we continue to believe that pamphlets and victim-blaming cautions about alcohol use will improve outcomes pertaining to heavy drinking and the associated risks, such as risks for unprotected sex and HIV exposure, or even depression. Why do we continue to do this? I mean, our findings, our evidence clearly points to the need for interventions beyond risk messaging regarding alcohol. Our work points to the potential benefits for investing in programs that might help people who experience childhood sexual abuse and recovery from that. Our work also points to the need to design employment and educational programs and opportunities that are flexible, low threshold, people can enter and exit, as their life demands create flexible models of that. And I think also there are points in our data that also point to the great significance of taking a comprehensive approach to reducing stigma associated with being gender or sexual, or being a gender non-conformant or being a sexual minority. And I think also very importantly, our trajectories reveal that if we did intervene effectively during young adulthood, it could reduce subsequent risks associated with heavy drinking, including drinking before and during sex, as well as depression. And I know what you're thinking. All right, this was an American study, Jeannie. It was, you know, an American study with data collected almost 15 years ago. You're right, we do. We need to understand if these patterns hold in today's young Canadian gay and bisexual men, or whether the trajectories that we built around alcohol and depression hold when we look at trajectories of drug use for other drugs, such as meth and cocaine. And we need to better understand, especially, these patterns within the context of an unparalleled overdose crisis and a contaminated recreational drug supply, as well as at the nexus of escalating health effects associated with sexual risks and substance use, including escalating STI and HIV rates among young gay and bisexual men. So we're cognizant that the world has changed. Today's young gay and bisexual men launch their sexual careers amongst a proliferation of social media, evolving legal frameworks, novel biotechnical advances in STI and HIV testing and treatment. And, you know, I'm involved in a pre-exposure prophylaxis trial, not for HIV, that work's already been done, but for syphilis. And as well, obviously changing gender norms and regimes are important to pay attention to. So needless to say, one more pamphlet just doesn't cut it, as if it ever did. And the kinds of government agencies that I work closely with, including the BC Centre for Disease Control and others, really appreciate this. And to help these organizations like the BC CDC, my colleague Dr. Rod Knight and myself and a large group of colleagues have launched a new 5-year research initiative, again funded by CIHR, to bring together the at-risk youth cohort and 3 other very powerful cohorts to expand and update the evidence base and Canadianize the evidence base in the hopes of informing and developing effective interventions that fit with this brave new world that young gay and bisexual men, and indeed all young people, are living in. And again, partnerships are key to this work, and I just really want to describe very briefly a few of those partnerships. We have a great partnership with the Health Initiative for Men, which is launching a series of interrelated interventions in response to its wish to address harm reductions and address harms associated with sexualized use of substances. And these interventions range from new clinical protocols all the way through to the distribution of clean meth pipes. I also am so pleased, could be a whole presentation in and of itself, but our continued and long-term partnership with the British Columbia Centre for Disease Control, and particularly my colleague Dr. Mark Gilbert, where we have co-designed, implemented and scaled up and evaluated the impact of Canada's first paperless online STI and HIV testing system, which we specifically designed for gay and bisexual men and for young people. Although it's open to anyone, you can log on and try it. It's a beautiful, seamless little device and intervention. We also work closely with a grassroots community organization called YouthCo, where we study the effects of empowerment, a community-based, community-initiated capacity-building intervention that aims to enhance the health and well-being of young, gay, bisexual, and trans men. And I'm particularly proud and happy to see this program and intervention scale up in northern British Columbia, where the context features incredibly hyper-masculinized social norms and intersect with this massive geography which presents incredible barriers to accessing appropriate health care or even educational opportunities for young gay and bisexual men. I mentioned briefly the idea of evolving legal frameworks as part of this new world context, and indeed I continue to work closely with Dr. Kate Shannon and a postdoc, Dr. Andrea Crucy, and others in government and community groups across the country, including the Canadian HIV Legal Network, on legal reforms, including legal reforms pertaining to the criminalization of HIV and the implementation of revised prosecutorial guidelines. And I'll just round out this set of examples of interventions that are built for today's context and where research is built into them by saying a few words about one of our longest running interventions in British Columbia in this realm, Campout. Campout is an annual leadership camp that is for young LGBTQ people, lesbian, gay, bisexual, trans, and queer people, and their allies, which is designed to build skills and networks to combat stigma related to being queer, young, and sexually active. And we're coming up to our 10th summer of Campout, and we've provided opportunities for over 600 young people from all over BC to participate in this 4-day camp and then return to their own communities alongside their friends, families, student allies, and allies in their community to instigate destigmatizing activities for the other 361 days of the year. And I just want to say, at Campout, we recognize the special and intense forms of stigma and their effect on non-gender conforming people. But our ethos at Campout is based on the idea that stigma, like all forms of social inequalities, affect all of us. And so it's to this point that I'm going to turn, as I close my presentation, to try to illustrate what I hope you will agree is a very important set of interconnections between the health of young people and the health of society as a whole. So let's go to a more global level for a moment. This is a map of the world, and the darker colors here, and it reflects median age by country, and the darker colors here reflect a lower median age. And you can see in Africa and other settings internationally that there is what some demographers call a youth bulge, if you will. A greater proportion of the population is young than old. And while the health profiles of young people differ markedly across and between countries and even within countries, I would say that it's pretty obvious the importance of investing in the health and well-being of the largest generation of young people in recorded history. I mean, it almost seems self-evident for countries who are shaded in darker colors here. Now, you'll also notice that Canada median age is somewhere between 40 and 50. I'm not going to get too specific on that. But, you know, you could think of the same idea of investing in young people in places like Canada or other OECD countries, and including in Europe. Investing in young people in these contexts is really, I think, about investing in a potentially small and diminishing, or at least a very precious resource that will become even more precious as predicted demographic trends unfold. And I mean, I think you've probably seen our inverted age pyramid, population age pyramid for Canada, where there is a much larger proportion of people in this segment of the population than there is in the younger segment of the population. You probably saw the big headline last summer where StatCan announced that Canada now has more people, more seniors than kids under 15. And even if you only focused on an economic level, we need to think seriously about the best ways to support healthy growth, healthy development, and success during adolescence and young early adulthood. Because, I mean, I think this slide actually puts it in very plain terms. Today, there are just 4.3 million Canadians between the ages of 15 and 24, compared to 4.9 million Canadians aged 55 to 64, many of whom are preparing or at least hoping to exit the labor market. And even at this very basic economic level, I think it's starting to become obvious we all need all of our young people to be healthy and to succeed, because their health and well-being is important for all of us. It's crucial to all of our futures. And just as the population age structures of country around the world vary significantly, there's real diversity within Canada's overall population. And no doubt you are well aware that the population age structure is on average much younger for Indigenous populations living in Canada than for non-Indigenous populations in Canada. And this is based on the most recent census data. So I think it's very clear that we live in a context, we live in a moment where tackling social inequalities facing young people can make important contributions to all of our futures. And the Lancet Commission on Adolescent Health agrees. They recommended and asserted that investing in young people could yield what they called a triple dividend of health and social benefits. They said that investing in young people could bring benefits to young people and their own health themselves during highly formative and important developmental periods. They also said that investing in young people could bring benefits into the future for those young people and improvements in their adult health and social trajectories. And thirdly, they also suggested that investing in young people today could contribute to the welfare of the next generation of children. But I actually would like to add a fourth dividend to that list of dividends, especially in light of the kinds of demographic trends that I've just shared with you. So fourthly, I would say that investing in young people today may be crucial to the current and future health and well-being of our society as a whole, including those of us who occupy this particular bulge in Canada's age pyramid. I'm just going to wrap up now by saying I've been in this business a long time, but I often hearken back to the year 1994. I hope all of you were born in 1994. But when this book first came into my life, Why Are Some People Healthy and Others Not? And I remember coming upon a paragraph in the introduction written by my colleague, Dr. Bob Evans. And this paragraph, I think by now I've probably read it or paraphrased it over 1,000 times. But I'll do it one more time for good measure. Bob wrote, There's something that powerfully influences health and that is correlated with hierarchy per se. It operates not on some underprivileged minority of them over on the margins of society, to be spurned or cherished depending upon one's ideological affiliation. But it operates on all of us. And it's that something, that big thing that operates on all of us. Something about hierarchy, something about the distribution of resources across health and social trajectories that shaped my approach to my work and indeed my life for these past 25 years. And I'll just close here by saying I really hope that we've reached a point where we can be courageous and make informed decisions that will positively affect the health of young people going forward and their futures, and indeed the futures of all of us. So I'll look forward to hearing your thoughts on all of this, and thank you very much for listening. I'm looking forward to the discussion.